Chapter 7, End-of-Life Concepts. We're going to complete our unit with this video, and we're going to talk about how to take care of the patient towards the end of their life, as well as their family members. We're going to talk about comfort. That's one of the major things that we need to do for our patients towards the end of life. We're going to talk about cognition, perfusion, and ethics. Death with dignity. What does that mean to you? Truthfully, death with dignity may be a little different for every patient. Death is part of the normal life cycle. We don't tend to think about it like that in our society, but it is normal. Everybody will do it. We can affect the dying process, though. We would need to make sure that our patients are able to experience death with dignity in the way that they think of dignity. So this is going to take some careful conversations with your patient. We want to promote a peaceful, meaningful death. We want to have that patient be free from distress all the way up till their dying moment, if we can possibly do that. We need to minimize the suffering for the patient and for the family as much as we possibly can. So what is death? What exactly is death? What does it mean to die? That may be a silly question, but let's talk about the pathophysiology of dying here for a second. It's the cessation of integrated tissue and organ function. It's the lack of a heartbeat, the absence of spontaneous respirations, or irreversible brain dysfunction. So, it's silly to think that we have to think about what dying is actually, but with the advances in healthcare, we have gotten to where we can keep a body, quote unquote, alive for a long, long time, but we always have to consider what dying truly is and if the patient is going to recover from their state or not. PSDA is the Patient Self-Determination Act, and it's a law that makes sure that each individual is able to make his or her own healthcare decisions. If they don't want blood products, you don't force them on them. If they don't want IV fluids, you don't force it on them. If they want to be in a DNR, you respect those wishes and do not code them. Let's talk about some of the documents that are associated with the Patient Self-Determination Act. What is an advance directive? An advance directive is a written statement of a person's wishes regarding medical treatment, often including a living will. Advance directives are made to ensure those wishes are carried out should the person be unable to communicate them to the doctor. A durable power of attorney for health care is a document that lets you name someone else to make decisions about your health care in case you're not able to make those decisions yourself. It gives that person, which would be called your agent, instructions about the kinds of medical treatment you want. There are a few things, though, that that person must be able to do to be able to be a durable power of attorney for health care. They must be able to receive information, number one. They must be able to evaluate, deliberate, and mentally manipulate information. And they must be able to communicate a treatment preference, the same as a healthcare proxy. All right, so they have to do those three things. Again, they have to be able to receive information, evaluate, deliberate, and mentally manipulate information, and they must be able to communicate a treatment preference. So let's think about an elderly couple. The man makes the wife his health care proxy. He has maybe colon cancer, we'll say, and he feels like maybe before too long he'll be in shape where he can't make any decisions on his own. In the last few months, the lady has developed Alzheimer's disease. Well, she is no longer able to legally be his health care proxy. So those kinds of legal entanglements do come up, and sometimes we'll have to educate our patients about some of those things. What is a living will? A living will defines wishes if the patient is near death. Do you want CPR? Do you want a ventilator? Do you want a feeding tube? That's what a living will is. A DNR is intended for people with life-limiting conditions for whom resuscitation is not prudent. But one thing you should know, by law, if there is no DNR order, you must do CPR. You have to. POLST, P-O-L-S-T, that's Physician Orders for Life-Sustaining Treatment. These are documents that give additional instructions in case of cardiac or pulmonary arrest. So what is the difference in a DNR versus a living will? A DNR is an order signed by a doctor which indicates that the patient should not be resuscitated. This has to be signed by both the doctor and the patient or their healthcare surrogate, healthcare proxy, or court-appointed guardian. Okay? A living will, on the other hand, is a legal document. It is legal, that allows an individual to state whether or not they wish to be kept alive by artificial means if they're terminally ill, in a persistent vegetative state, or in an end-stage condition. The individual can state their specific preferences as to whether they wish to be kept alive with life support or other medical treatments. They can also list who they wish to name as their healthcare surrogate, or the person that will make those decisions for them in the event they cannot do so themselves. So this is something that is made in advance of getting so sick that they can no longer make decisions for themselves. That's the living will. Some states have a kind of a combo deal, and in Louisiana they have something called the LA Post. Some people call it a La Poste. But what it amounts to is it is a step-by-step delineation of what you should do for the patient according to their will or the healthcare surrogate's will. It's signed by the physician and the healthcare surrogate, and this document goes with them wherever they are. So you don't have to get, like if on this document, if they say that they want to be a complete DNR, you no longer have to get another order signed every time they come in the hospital. This travels with them. So if they go to the nursing home, it goes to the nursing home and it stands there. If they come in the hospital, go back home and then come back in the hospital again, you have it with them. You have the original paperwork each time. It should be passed back and forth between facilities, but a copy will do in a pinch. Just know that sometimes when a person comes in, the family member does not think about bringing that document with them. So you have to make sure that you ask about it on admission and that you try to take care of that right away so that you are aware of what the patient wants as far as resuscitation. And that's being an advocate for your patient. Hospice. What is hospice? People usually go into hospice if they're kind of have less than 6 months to live about. And hospice is there to help provide expert medical care, pain management, and emotional and spiritual support specific to each patient. So this is your patient-centered care again. And it's going to be according to the patient's needs and wishes. They are there for both the patient and the family. And it's really not, for hospice, it's really not about dying necessarily. It's more about living the best life that you can all the way to the end and having a dignified end. What is palliative care? It's a consult for people with life-threatening disease done by a physician or a nurse practitioner, and it helps patients and families identify outcomes for care. It helps inform them so that they can make decisions and helps facilitate quality symptom management. So what's the difference in the two? Hospice care is intended specifically for the end-of-life period, generally for patients expected to live for less than 6 months, like we said. Palliative care is recommended for patients at any stage of a life-threatening or chronic illness. So the intent is not to treat or cure the disease, but to ease any symptoms and side effects the patient is experiencing while preparing for, undergoing, and recovering from treatment, as well as once treatment is over. Right? Pause this recording right quick and make sure that you have your book. And then you're going to want to turn to page 107. We're going to look at chart 7-1. All right, let's go through this chart because these are common physical signs that death might be approaching. And when you are part of hospice maybe, or even home health or whatever, and you're providing care for a patient that is nearing death, some of these things you need to know, okay? So the first thing is coolness of the extremities. Whenever a patient is dying, their circulation to the extremities begins to decrease. Their skin may become kind of mottled or cyanotic, especially in the extremities. But what is mottled looking? It's splotchy, kind of splotchy looking. I'll try to make sure that I have a picture on this slide so you can kind of see what mottled looks like. You just need to know you should not use an electric blanket, a hot water bottle, any kind of electric heating pad or hair dryer to warm the person up. This often is the body's response to try to keep the blood pressure up, which means that they clamp down the vessels in the periphery of the body, so in the extremities or the outlying regions of the body, to shunt blood to the main organs in the body. So you have the potential to hasten death if you warm them up too much. Now, with that being said, you always want to keep the patient comfortable. That is what it's all about. So if they request that they want a warm blanket or a heating pad or whatever, do that for them. Do it for them. When they start to increase their sleep more and more, you know that death is probably near. And what happens is the metabolism is decreasing and they just don't have the energy to spend staying awake. And we can tell our patients' families, or if you are the hospice nurse, this is the time you want to spend sitting quietly with the person. Don't force them to stay awake, but be there in case they do wake so that you can talk to the person as you normally would. And even when they are in kind of a comatose state like this, we want to encourage our family members to talk to them just as if they were awake and alive. Now this is, I'm sorry, not alive, they are alive, but awake and alert. And this is a little awkward for some people, but if they see you doing it, then they might model you. And this is some communication that some people really need to be able to deal with the death of their loved one. Because the metabolic needs are decreased, they're just not going to be as thirsty and hungry at all. You don't want to force them to eat either. Just let them do what they're going to do. You just want to offer little chips, little ice chips, or little sips of water every once in a while at frequent intervals if they're alert and able to swallow. And this is for the patient comfort. We want to swab their mouth out. A dry mouth and lips is just really uncomfortable. So as part of our comfort care, we want to make sure we do good oral care and keep those lips moist. And we can do that by putting a lip balm on the lips frequently. When they're near death, they're going to have incontinence because the perineal muscles begin to relax. So we want to make sure we keep them dry and clean. Use chucks or disposable underpads. Adult briefs are important here. And sometimes if this happens, the physician will order a catheter, a Foley catheter, just for comfort's sake for the patient. Have you ever heard a patient with that death rattle, that gurgle? Sometimes you know that death is imminent when that begins to happen, and it's because they can't cough up their secretions or swallow their secretions anymore. Whenever this happens, you want to put the patient on their side and use a toothette to gently clean the mouth out of secretions, or a suction like a Yonker suction. And there are also medications that you can do to decrease the production of some of these secretions. Their breathing pattern. When they begin to die, the circulation just goes down to all the organs, including the brain, and they may start to breathe really shallow. You just want to elevate their head and, even position them on their side, whatever position makes them most comfortable. Near-death disorientation is usually a problem too, and it has to do with the flow of blood to the brain. Whenever you're talking to the patient, always identify yourself, even if you think they know who you are. Hey, Miss Jones, it's Terry here again. I'm going to whatever. You want to reorient the patient as you need to. Speak softly, calmly, and truthfully. You don't want to mince your words at this time in their life. Sometimes they'll just become restless. And this also has to do with poor circulation to the brain. Just some soothing music might be helpful. Don't restrain them. I mean, they're on their deathbed. Don't tie them down, please. Don't do that. Massage their forehead, their temples. You may need to reduce the noise in the room, so maybe only 1 or 2 people in at a time. Talk quietly. Keep the room dim. You want to keep the noise level at a minimum, and you might even consider sedation if these other measures don't tend to work. All right, so let's move on to the next slide. Don't forget to assess coping skills. How are they coping? Assess their level of anxiety. If they seem to be having trouble coping, make sure you talk about any cultural considerations, their beliefs, etc. Let's look on page 108, since we've got our books out here. Let's look at the HOPE mnemonic on page 108. You see it down there under the pink box? When assessing a patient's spirituality at the end of life, we're going to use this HOPE mnemonic. And H stands for, what are your sources of hope and strength? Have them think about their sources of hope and strength. O, organized religion. Do they have any organized religion, and how does it play out in their lives? P, personal spirituality, rituals and practices. What kind of personal spirituality do they have? Do they have any ritual practices that might help them cope with their end-of-life situation? E, what are the effects of religion and spirituality on care and end-of-life decisions? So what does their culture dictate that goes on at the end of life? Do they not want anybody around? Do they want everybody in their family around their bed? Do they want last rites administered by their priest? These are just things that you need to make sure that you address with every patient that is dying. The desired outcomes for a patient near the end of life are that the patient will have their needs and preferences met, that any distress symptoms will be controlled, that they'll be able to have meaningful interaction with their family, and a peaceful death. Although the perception of hospice is that it provides care for the dying, the major focus of hospice is not dying. It's on the quality of life all the way to the end. And controlling those symptoms, this can be tricky. Pain is what most of these patients fear most. So help them get that multimodal type pain control going. We've talked about the opioids and the non-opioids. You may have to play around with the doses to get it just right in a combo, and it may depend on the route available. You can get sublingual opioids, rectal opioids, etc. Remember that those patients that stop making urine will have opioids hanging around in their system, okay? So you may think about decreasing the dose of the opioids when they stop making urine because they're no longer being cleared from their system. They'll be hanging around in the system longer. You just have to really assess and confer with the physician on things that you need to do at this time. Non-medication type interventions or complementary interventions can be very helpful as well, like massage. Whenever you do massage, you need to make sure that you don't massage over any areas of damage, like where a tumor is, because that can be painful. Maybe just slide your hand over that area and gently rub the skin, but don't press. Be mindful of how hard you massage, because massage can be very relaxing. It can also be painful if you do it too hard. Music therapy can be important. Therapeutic touch. You need to pat their hand or rub their arm. Just that human touch is calming to a lot of people. But again, also take cues from your patients. Some people don't like to be touched. I have a friend that doesn't like to be hugged, and it's really hard for me because I'm a hugger. But I try to remember that and just give her an extra big smile instead of a hug. Aromatherapy can be helpful. Don't be scared to try them all. What's it going to hurt? So think about what your idea of a peaceful death is. For me, it would be my family in the room with me, very quietly singing hymns that I'm familiar with from church. I can't stand loud noises. So that would be ideal for me. Everybody's different. You have to communicate with your patients. Let's talk about managing weakness near death. Weakness sometimes brings about a huge potential for aspiration. So we have to take aspiration precautions. What are aspiration precautions? You're going to sit the patient up at 90 degrees when they're eating. That seems really high, doesn't it? But they need to be sitting straight up. Keep the patient at 30 to 45 degrees at all other times, especially if they have GERD and tend to aspirate at night while sleeping. Keep suction nearby. These are all of the aspiration precautions. So 90 degrees when eating. Keep the patient at 30 to 45 degrees at all other times, especially if they have GERD, and keep suction nearby. What kind of test can tell me if my patient is aspirating? Well, you might do a chest x-ray, but really a swallow study is the best way to determine if a patient is aspirating. Who does swallow studies? Speech therapy, which I always thought was a little odd, but they do. They do swallow studies. So let's talk again how uncomfortable we can be if our lips get dry. Don't let these poor dying people lay up there with their mouth wide open, lips and tongue cracked and gross. Use swabs to clean that mouth. Use that lip moisturizer. And a lot of these lip moisturizers can also be used on the tongue, which sounds disgusting maybe to you and me to have that on our tongue, but if your tongue is dry and cracked, it will be a lot more comfortable than that. We've talked about that you may have to alter the route of administration of medications. That's just part of your assessment and see how it's going. Depends on if they're still able to swallow or not. Let's talk about how to alleviate shortness of breath in the dying patient. Opioids, especially morphine, actually relaxes smooth muscle. So what are the bronchial tubes made of? Smooth muscle, lined with mucus glands and cilia. So opioids will also give the patient a feeling of well-being. Bronchodilators. Name one. What's a bronchodilator that you can name? Albuterol is the most common, and they help relieve bronchospasms. What about diuretics? Diuretics help remove any extra fluid from the body. That might help their shortness of breath. Antibiotics, of course, to get rid of any infection that may be making them short of breath. What about anticholinergics? These are those drying agents that I was talking about to dry up that death rattle, like atropine and scopolamine. And they really are helpful in that death rattle, and a lot of times that will make the patient more comfortable as well as the family. Benzos for anxiety relief. And these meds may have to be given around the clock in a timed fashion and not PRN to get these shortness of breath or dyspnea issues under control. Oxygen by cannula can sometimes help shortness of breath. It's used for comfort here, so we're not really concerned about knocking out their hypoxic drive or keeping their pulse ox greater than 92%, etc. It's strictly for comfort. You're going to try to limit their exertion. They may need a catheter like we talked about. Keep the head of the bed up or have the patient sit in the recliner to sleep if he's able and wants to. Apply a wet cloth to their face if it helps. You want to just encourage slow, deep breathing whenever they're anxious and feel like they can't catch their breath. Reposition the patient. If the patient has a big tumor in the right lung, they may prefer lying on that side to keep their good lung up. Just let them. That's fine. All right, we've talked about managing that shortness of breath. Now let's talk about managing nausea and vomiting. Nausea and vomiting can be a problem because they're getting a lot of meds. Let's talk about, well, antiemetics first. There are different antiemetics that you can give to help control this nausea and vomiting. You can give Compazine, Zofran, dexamethasone, Reglan, and these can tend to help them not be so nauseated and vomit. You need to remove any odors and don't wear heavy perfume. This can lead to increased nausea for them. Keep the temperature in the room comfortable for the patient. If they're too hot, they might get really nauseated. Some type of aromatherapies can help, like chamomile, camphor, fennel, lavender and peppermint, and rose can help relieve nausea, but some patients may have the opposite reaction and vomit more. So ask the patient if they would like to try it before you do it, and then evaluate if it works or not. And of course, always respect culturally established practices. If they say sticking a spoon on a string and dangling it from an ear helps nausea, then do it or allow it to be done. The mind is a powerful thing. If they believe it's going to help, it just might help. Managing agitation and delirium. We want to always assess for pain, urinary retention, constipation, and other reversible causes of agitation and delirium. Okay, we're going to look at their pharmacologic agents. Maybe we'll use music therapy and aromatherapy. And you remember what delirium is from previous lessons. If you don't, you need to go back and review that. Make sure you know what delirium is. If the patient has refractory symptoms of distress, you might consider proportionate palliative sedation. This is just a continuous drip of something like Versed, Ativan, maybe even Diprivan at a small dose. The intent of this is to promote comfort and not hasten death. So this is not to be used for euthanasia. It is just to help control any of those symptoms that you haven't been able to get under control with other measures. Meeting their psychosocial needs. Grief is one of the big ones. That's the emotional feeling related to the perception of loss. They're going to be mourning. That's outward social expression of the loss. And we want to do our interventions based on cultural beliefs, values, and practices. Okay? It's important to first assess what patients and families understand about the illness and then help them identify the desired outcomes for care according to their own beliefs, values, and cultures. Because people experience grief in different ways. Be with the patient and family, not just there, but an active part of what's going on. You're going to say things like, "I'm so sorry this is happening," or "I know this must be difficult for you." Do not say things that might minimize their experience. So don't say things like, "It'll be fine. In a year you will have forgotten all about it." Don't say that to the patient or the family. Don't say, "Don't cry, it'll be fine." Don't tell them to not be upset. They're going to be upset. Just empathize with them. "I'm so sorry this is happening. I know it's hard for you." You want to encourage storytelling and reminiscence for the dying patient. Encourage the family to be present for the death. It helps them to accept the death. Don't try to explain the loss. Don't say everything happens for the best. Don't say God doesn't send us more than we can bear. This minimizes their experience. Ask what you can do to help and tell them you're sorry for their loss. That's about all you can do. Unfortunately, there are always legal considerations in our profession, even at the end of life care. If a patient dies in hospice care, the family calls hospice. If not, then the medical examiner is notified to pronounce death. Some states allow nurses to pronounce death in nursing homes and other long-term care facilities. After preparing the body, bathing and combing the hair, dressing in clean clothes, changing the sheets, etc., you need to allow the family time alone to say goodbye to their loved one. You also, in the hospital, have to determine the need for an autopsy. What are the legal reasons why you might need an autopsy in your facility? What are your policy and procedures? And then you have to coordinate the transfer of the body to the chosen funeral home. Or if they're having a wake in their home, to their home. How are you going to do that? You have to be in communication with the family and maybe even get some ideas about what kind of things are available to the family in the community. Active euthanasia is not supported by most organizations. Neither is physician-assisted suicide. We're going to talk about passive euthanasia and voluntary stopping of eating and drinking. Okay, passive euthanasia. This is like withdrawing someone from the ventilator if they're brain dead. So how do you feel about passive euthanasia? What do you feel about active euthanasia? Active euthanasia is giving someone a medication that you know will end their life. What about physician-assisted suicide? How do you feel about that? What about voluntary stopping of eating and drinking? Should you allow the patient to do that, or should you try to force them to eat and drink? As always, your instructions for the unit will be in Brightspace. There are going to be some questions that come up on the next slide after this video here in Nearpod. And you're also going to have a discussion board question to answer in Brightspace. You're going to put your answer in there, and then you're going to respond to 2 other people. And it can't be something like I just agree, okay? You need to be specific about what you agree with and why you agree with it, or you need to be specific about why you don't agree with whatever they said. Okay? You're also going to have a short paper to write about the end-of-life care. It's going to be 100 words, and it needs to be in APA format. If you have any questions about APA format, you can either Google it or come ask me how I want this to be done. You're not going to have a cover page. Basically, with the APA, I want it done with the correct margins, the correct font, the correct size of the font, and the correct spacing of your sentences. I think it's double spaced. I'd have to look. But look up the APA format and do that in that format. And the reason you do things in APA format for this class, for the associate's degree class, is because when you do BSN, which I encourage you to do, and I hope that you will continue on and get your BSN, when you do that, you will be writing a lot of things, and they all have to be in APA format, so we might as well start practicing now. Okay, for your paper, you need to make extra sure that you do not plagiarize. All right. Any information that you find, you need to make sure that you cite correctly in APA format, and that you have a works cited page attached to your paper. And like I said, you can find all of this information, how to do this, online. But if you have questions about that, come to me and I'll discuss it with you, okay?